How have sling materials changed for bladder incontinence surgery? How have sling materials changed for bladder incontinence surgery? This is an important question for anyone considering treatment options for urinary incontinence. Over the years, sling materials have evolved significantly, reflecting advancements in medical technology and surgical techniques. Initially, sling surgeries relied on autologous tissues, which are tissues taken from the patient's own body. Surgeons would use muscle flaps or connective tissue harvested from areas like the thigh or abdomen to create a supportive sling under the urethra. While these autologous slings had the benefit of being biocompatible, they required more invasive procedures and longer recovery times. In the 1960s, the introduction of synthetic slings marked a significant shift. The first synthetic materials, such as mersaline ribbon, were used, but these early options were linked to serious complications, including fistula formation and tissue sloughing. This led to a search for safer alternatives. A major breakthrough occurred in the 1990s with the introduction of polypropylene mesh for mid-urethral slings. This durable synthetic material provided strong support and had fewer complications compared to earlier synthetic options. The tension-free vaginal tape procedure, which utilized polypropylene mesh, became a popular choice due to its high success rates and less invasive nature compared to traditional surgeries. Following this, the transobturator sling approach was developed. This technique used the same polypropylene mesh but altered the placement route to reduce risks associated with the retropubic approach, such as injuries to the bladder or bowel. More recently, single-incision slings, often referred to as minislings, have emerged. These use shorter strips of polypropylene mesh that are inserted through a single vaginal incision. The goal is to minimize surgical trauma and reduce the risk of complications. However, long-term data on their effectiveness and safety is still being studied. In addition to synthetic options, there has been renewed interest in biologic grafts. These include allografts, which are taken from cadaveric sources, and xenografts, which come from animals. Biologic grafts may be suitable for patients who prefer non-mesh options or who are not ideal candidates for synthetic materials. While they can reduce the risk of complications associated with synthetic mesh, their durability and success rates can vary. In summary, sling materials for bladder incontinence surgery have evolved from autologous tissues to advanced synthetic meshes, with ongoing improvements in techniques and designs. The choice of sling material depends on individual patient factors and surgical considerations. It is essential for patients to consult with healthcare professionals to determine the best approach for their specific needs, especially when considering bladder health and potential complications.